Hello, so my name is Sigrid Carlsson. I'm an assistant attending epidemiologist at Memorial Sloan Kettering Cancer Center in New York. And I'm pleased to be here today for Grand Rounds Urology to present this trilogy on screening and prevention of prostate cancer in 2021. So this is I'll start with my disclosures. And this is a trilogy in 3 parts. So the first part is the evidence for PSA screening. The second part is who needs a biopsy or who doesn't need a biopsy. And part 3 is on incorporating MRI in the early detection of prostate cancer. So let's start with the first part on the evidence of PSA screening. So as you know, the PSA test was first proposed as a marker of cancer in the late 1980s, early 1990s. And we have these landmark screening studies by Dr. Stamey and Dr. Catalona that really set the stage for PSA testing in the US and then worldwide. And I think we can all agree that PSA screening has been a success story because we have evidence from 3 large randomized trials with long follow-up that provide evidence of the effectiveness of screening. We have the ERSPC trial in Europe, we have PLCO in the US, and we have the Swedish Göteborg trial. And as you are probably all well aware, regular PSA testing every 2 to 4 years in the ERSPC reduces prostate cancer mortality by 20%. And with 18 years of follow-up in the Göteborg trial, this confirms that PSA screening reduces mortality by 35%. And you can see that the number needed to invite to screening and the number needed to diagnose to prevent 1 death from prostate cancer becomes more favorable over time. So at 18 years in Göteborg, these numbers are 231 and 10 respectively. In the US trial, the PLCO trial, there was no evidence of a mortality benefit for organized versus opportunistic screening at 17 years. And this was because many men in both arms of the trial received a PSA test. So it was really difficult to detect a difference between the 2 trial arms in terms of statistical power. And when you take this into account and when you do sophisticated modeling of looking at those who attended the screening and PSA testing, you can see that both the European and the US trials provide compatible evidence that PSA screening reduces prostate cancer mortality by about 30%. And the balance between benefits and harms of screening really improves over time. So when you model this out over a lifetime and a 25-year follow-up, you can see that the number needed to screen and the number needed to diagnose to prevent 1 death from prostate cancer become more favorable. So you now have numbers of 385 and 11 in the ERSPC trial at 25 years. If you look at the observational data, you can see that the death rate from prostate cancer in the US has declined from the mid-90s through 2010, but has now stabilized in recent years. And that is followed the fewer men having PSA tests in recent years due to the changes in the guidelines. And we now see a definitive and sustained increase in prostate cancer metastases in the US consistent with these decreases in PSA screening. So in these figures, you see a gradual increase in the incidence of distant metastases over time, both in men 50 to 74 and also in men over the age of 75. And interestingly, the COVID-19 pandemic has also led to a large screening deficit for both breast, colorectal, and prostate cancer. And in this figure, you see here that the blue line is 2020, where you can see from February onwards a big drop in PSA testing, and then it catches back up again as the pandemic has eased up. But we still have a large deficit in PSA testing. So prostate cancer, as you know, is a major public health problem. It is the 2nd most frequent cancer and the 5th leading cause of cancer death among men in the world. And the incidence of mortality really varies over the world. You have the highest incident rates in the Northern and Western Europe, the Caribbean, Australia, New Zealand, Northern America, and Southern Africa. And the lowest incident rates are in Asia and Northern Africa. And the highest mortality rates are found in the Caribbean, Sub-Saharan African, and the Micron Polynesia. So you really have a different pattern of disease over the world, and that reflects differences in risk factors, but also differences in screening and treatment patterns. So what can we do to prevent prostate cancer? Well, you can't really prevent aging, but age is a risk factor for prostate cancer. As you know, this is in the US, the median age of diagnosis is around 66, and the median age at death from prostate cancer is about 80. We also know that men who have family history of prostate cancer have an increased risk. So if you have a first-degree relative, your risk is almost twofold increased. And men of African ancestry also has an increased risk of prostate cancer, aggressive prostate cancer, and lethal prostate cancer. There are also genetic changes that affect risk of prostate cancer, and these are results from the IMPACT study that show that men who have a BRCA2 mutation have higher incidence of both any prostate cancer and clinically significant prostate cancer, and are also at risk of having early onset disease, so they're younger at diagnosis. So a lot of guidelines now suggest systematic PSA screening for these men, but further follow-up is needed for those with a BRCA1 mutation. And here you can see how this is incorporated in the guidelines, where we have age, we have ancestry, and we have genetics incorporated in the screening algorithm. So this is an example of the NCCN guideline, where you can see that men who have African ancestry or genetic risk factors of family history are recommended to start screening at age 40, as opposed to 45 for men at average risk. The EAU guidelines also have similar recommendations, that you start at 50 for those for average risk, and then 45 if you have family history, and the same with men with African descent, and those who carry BRCA2 mutations are recommended to start at age 40. Another very strong risk factor for prostate cancer and lethal prostate cancer is the PSA level in midlife. So here's a study from Sweden where you have men ages 51 to 55, and you can see with long-term follow-up over 20 years that those who have PSAs in the top 10%, so in this case above 2.4, they have a high risk of metastases at follow-up, so about 5%. And in contrast, those who have a very low PSA, less than 1 in this case, or 0.9, they have a 0.3% risk of metastases over follow-up. So having a PSA below the median for your age is very favorable. And this has been shown in multiple studies. This is Mark Preston's work comparing the Southern Community Cohort study, which included 100% Black men, and the Physicians' Health Study, and then the Malmö Preventive Project, which contained predominantly white men. And you can see that the PSA, the baseline PSA captures aggressive prostate cancer at least as well in Black men as in white men. And you can see that the PSA distributions and the median PSA concentration is very similar across the cohorts. Here's another study on this concept of baseline PSA at age 60 in predicting lifetime risk of metastases and death. And again, another Swedish study from Malmö, where men gave blood in the early 80s and were followed for 25 years. And you can see that the majority of prostate cancer deaths, so 90%, occurred among men who had a PSA above 2 when they were in their 60s. And in contrast, if you had a PSA below 1 when you were 60, you were very unlikely to die from prostate cancer. So the risk at age 85 was only 0.2%. And here's another study that we did comparing men who were regularly screened in the Göteborg screening trial compared to men who were not screened in this Malmö study. And again, you see this discrepancy between PSA levels. So if your PSA is above 2, there's really a benefit of continuing to screen those men. So you have a large reduction in cancer death from continuing to screen men who have a PSA above 2 at age 60. And in contrast, if you have a PSA less than 2, if you continue to screen those men, you really have an increased risk of prostate cancer diagnosis, but no decrease in cancer mortality. So the benefit to harm ratio really varies with your PSA level for your age. And here's again confirming this finding in the PLCO trial, where we saw that repeated screening can be less frequent in men who are 55 to 60 and have a low PSA less than 2. And we have used these studies to incorporate this in our guidelines. So this is, for example, the Memorial Sloan Kettering Cancer Center guideline, where you can see that, for example, if a man is between 60 and 70 and his PSA is about 3, then of course you can talk to your doctor about having a prostate biopsy. If it's between 1 to 3, then we recommend screening every 2 to 4 years based on the USPC trial. But then you see if the PSA is less than 1, then no further screening is recommended for these men. And finally, screening, as you know, does reduce prostate cancer mortality, but it is offset by a reduction in quality-adjusted life years. So even though the mortality is reduced by 35%, and each man saved from prostate cancer death have an average lengthening of life of 8 years, you see that there is a 23% reduction in the life years gained due to impaired quality of life. And the majority of this comes from the long-term side effects of treatment for prostate cancer. So screening really comes with benefits and harms. And over a lifetime horizon, the number needed to diagnose to prevent 1 death from prostate cancer is 5. So we'll talk more about the balance between benefits and harms in the second 2 parts of this trilogy. And we coined these 5 golden rules to really shift the balance so that it becomes more favorable. So we keep the benefits and we reduce the harms. And we will discuss these in the second 2 parts of this trilogy. So the first is get consent, engage in shared decision-making. 2, don't screen men who won't benefit. 3, don't biopsy without a compelling reason. 4, don't treat low-risk disease. And 5, if you have to treat, refer men to a high-volume provider. Thank you.